Thank you very much. Hopefully everybody can hear me well. We did a good sound check before, and we had a clear signal. And I want to thank you for joining us today. Liver cancer is now the #2 cause of cancer deaths worldwide. This is information released by the WHO just a few weeks ago. Therefore, a very timely topic. We'd like to thank you for joining our CME event today. You already heard about sign-in sheets and assessments. We'll be walking through some specific questions now to get you oriented to our program. There is a disclaimer and disclosure of unlabeled use that you've already heard about, and we'll make sure to highlight those during the presentations if relevant. I work with a number of pharmaceutical companies on both the advisory boards and speaking. That pharma money is recycled back to research, education, and philanthropy. Activity, here's our agenda. We've got a pretty fast-paced case series and data we're going to be walking through, so keep things moving along, but you'll have enduring materials to review in the future at your convenience. Learning objectives, we want to identify risk factors, including the type of underlying liver disease and how to assess patients on presentation with liver disease and presentation with new liver tumors. Treatment plans will be discussed. We'll be outlining tumor characteristics. We'll be talking about recent clinical trial characteristics, about novel agents that are being evaluated to treat advanced HCC, and devise strategies to integrate targeted agents into both plans for current and future therapy for your patients. A multidisciplinary approach is critical for managing liver cancer patients today and would be considered standard of care. Demographic question 1. If you are a physician, what is your primary specialty? Please check the box or fill out the bubble. Medical oncology, surgical oncology, radiation oncology, some type of radiation therapy that's not oncology related, internal medicine or primary care, gastroenterology, hepatology, pathology, medical oncology fellow, or another physician type not identified. Let's move on to question 2. If you're not a physician, what's your primary specialty? Pharmacy, nurse, nurse practitioner, physician assistant, research, data monitoring, industry, academic, or other. Thank you for helping us with these important questions. Question 3, in a typical month, how many patients with liver cancer do you treat? 1 to 5, 6 to 10, 11 to 15, 16 to 20, greater than 20, or are you not actively treating liver cancer patients today? Practice patterns and trends. This is a survey question now. What treatment do you utilize most often for a patient with unresectable HCC who is not a transplant candidate? Sorafenib, placing them in clinical trials, some type of ablative therapy, thermal ablation, of course, such as RFA or microwave, transarterial embolization case, bead embolization would fall under number 5 as well. Radioembolization is number 6, external beam stereotactic body radiation, or other. Thank you very much for helping us with these survey questions, and now we're on to number 2. Please rate your level of knowledge regarding sorafenib for the treatment of HCC. No knowledge, limited knowledge, somewhat knowledgeable, or very knowledgeable. Survey question 3. Please rate your level of knowledge regarding novel targeted agents. Of course, this is really pointing at clinical trials. No, limited, somewhat, or very knowledgeable. Question number 4, a new medication that's in development, ramucirumab. No knowledge, limited, somewhat, or very knowledgeable. Let's now move to the core presentation. We're going to review epidemiology and diagnosis. Which of the following is true for LIRADS? And just to give you a little bit of background, LIRADS is a new system of scoring liver tumors in patients with underlying liver disease who are undergoing surveillance for liver cancer or imaging for liver cancer. and the scoring system goes from 1 to 5. Is this a system of standardized terminology and criteria to interpret and report imaging characteristics? Or does this apply to patients with cirrhosis or at risk for HCC? Does this categorize observations from 1 to 5, reflecting probability of being benign or cancer in at-risk patients? Is it 1 and 2? Is it 2 and 3? Or is it all of the above? Please answer this question about LIRADS. Liver cancer, 5th most common cancer in men, 7th in women worldwide. And I started out by telling you some new information that just emerged. This emerged after the slide deck was developed, so we're going to have to change bullet 2. It's the second leading cause of death from cancer worldwide. And incidence and death rates are rising. It's the fastest rising cancer in the United States at this time. It's primarily due to hepatitis B, C, and NASH. Fatty liver. Globally, every 30 seconds, someone is dying from liver cancer in the world. These deaths are preventable through a variety of interventions that we'll talk about today, including things like vaccination for hepatitis B, stopping hepatitis C spread, getting people to lose weight. Many of these cases occur in sub-Saharan Africa, Asia, Southeast Asia, Eastern Mediterranean, and Central Asia. This geography makes up about half of the world's population. Famous people such as Johannes Brahms, Ray Charles, and Edith Piaf died of hepatocellular carcinoma. This is bringing it closer to home depending on your music tastes. The epidemiology in USA 2014 are highlighted on this slide. We're thinking 33,000 new cases in this country this next year. Men more than women, almost a 3-fold difference, maybe explained by iron, testosterone, or polymorphisms in the immune system or cytokine system. Not all those patients will die immediately. We have a number of ways of prolonging life, quality of life, and of course, we've mentioned cure. Liver cancer can be cured by transplant and in some cases by resection or ablative therapy. This again just gives you a contrast that more men than women are dying because of the proportionality of the disease state itself. This is highlighting 2 items just in terms of percentile, liver and intrahepatic bile ducts for men and women in the red boxes. U.S. burden of disease, HIV and AIDS deaths are falling, cirrhosis rising, liver cancer rising substantially, increased event rate and increased death rate. And this is contrasting 1990 to 2010 over these last 2 decades. Liver cancer mortality in the U.S. varies widely by geography. This may have to do with socioeconomic issues, insurance, and access to care, plus other factors. Mortality from cancer in obese men. Liver cancer is much higher. As you know, obesity increases the rate of a variety of different cancers. And then once you have cancer, probably because of signaling factors, maybe insulin or insulin growth factor receptors related to the hyperinsulinemia you see in fatty liver, may be contributory to this death rate. Or patients who are obese get less medical care, less interventions. These are all possibilities. Pathogenesis of hepatocellular carcinoma. There's a many-step process. Genetic alterations, insertion of hepatitis B genome, signaling pathways that are disrupted, including TGF-beta, P53 mutations. These are oncogenes that may de-repress control of cell proliferation, inflammation, viral hepatitis, diabetes, NASH. Many, many different items are influencing how these cell changes and evolve over time and eventually proliferate into cancer. Relevant pathways. It's a very complex slide, and I'm not going to spend much time, but this is just telling you that in pharma, in development, there are many targets that are inside these liver tumor, liver cancer cells. And it is pluripotential. There are going to be needs for drugs that target multiple pathways, just like you would treat HIV with a minimum of 3 medications. Hepatitis C, a minimum of 2 or 3 medications. Liver cancer is going to require, in my belief, in the future, a multi-phase approach. First-generation drugs such as sorafenib are considered, quote, dirty kinases because they affect multiple downstream pathways and affect receptor signaling from things like VEGF and hepatocyte growth factor. Molecular signatures. Basically, this slide is talking about biopsying, looking at cell types, cell signaling, cell signatures, and deciding who has a better chance of survival or a poorer chance of survival. Eventually, we'll be biopsying all patients with liver cancer, profiling those patients, both for prognostic purposes and selecting different medications. Cluster pathways had to do with a variety of different signaling that are highlighted on cluster A here. Well, you know there's a number of medications out there that interfere with the mammalian target of rapamycin, mTOR, such as sirolimus, temsirolimus, or everolimus. And this class of drugs is being looked at to treat HCC, either alone or in combination. We don't have a clear signal yet about these medications and their management of HCC, but there's some suggestions that they may be part of a multi-treatment approach to HCC. Targeted therapy, we've already mentioned VEGF. We can target through other pathways, angiogenesis. We can talk about cell adhesion molecules and decreased metastatic disease. These different tyrosine kinases, we can inhibit downstream events to try to block HCC either development or disease state once it's present. Well, let's go to imaging. The standard of care today is to do ultrasounds every 6 months, which is called surveillance, not screening, but surveillance for liver cancer. But if you have, for instance, an abnormality on ultrasound, or if you have rising biomarkers and your ultrasound is negative, I'm just showing this graph to show that MR scans are more sensitive and specific than CT scans. So ultrasound and MR are our favorite 2 paired imaging modalities to pick up and detect and diagnose liver cancer. Liver cancer today is diagnosed by imaging, not by biopsy, in the great majority of patients. Liver-specific MRI contrast agents have been developed, and the specific one is called EOVIS, which is cell-specific. Actually is taken up by hepatocytes and not taken up by liver cancer cells. So in a 3rd, 4th, or actually what I call a 5th phase of the sequence of MR, EOVIS can help determine if the patient has cancer or not cancer or potentially a dysplastic lesion. Definitely a complement to our current standard MR imaging and CT imaging. Surveillance works. This is a trial from China by Zhang, published a decade ago, showing that survival probability was better in the screening than in the control group. This is a very large prospective study, not a perfect study, but the best study we have to date. It showed a marked difference in survival, screening, and then surveillance. Regular testing, that surveillance works. What about treating that cancer? Right now, our best options, besides transplant and resection, are to do what's called percutaneous ablative therapy. On here, there's a whole number of different options, but RFA, which is the 4th one down on the left side, is really considered the standard of care in patients that can tolerate a percutaneous or laparoscopic approach. This involves putting a probe into a tumor, heating the tumor, and in a subset of patients, maybe 15 or 20%, you can have long-term cure, at least of the primary lesion. Of course, if you leave the diseased liver in place, there's high risk for recurrence in other parts of the liver, pointing back to transplant as the ultimate way to cure hepatocellular carcinoma. Survival rates in Asian patients by different treatment modalities, again highlighting that patients with liver cancer have the best chance of long-term survival. This is going out 150 months. 50% of those patients are alive. Patients with other treatment modalities, much poorer survival. But in the green line, RFA, at least short-term, in the first 5 years, can parallel hepatocellular carcinoma. But that RFA is being applied to selective patients with good liver function, no ascites, and very importantly, treat the underlying disease that's in the background. What about patients who are treated with hepatitis C, who have sustained virologic response or cure? What's the 5- and 3-year cumulative incidence of liver cancer developing? Basically, much lower rates of cancer in patients who have had an SVR, have had a cure. That's the second pair of bar graphs that are there, 2.5. Patients who did not have a virologic or biochemical remission, 5 years later, 20% chance of having liver cancer. So that's 8 times higher than patients that are cured. We want to treat, we want to cure, we want to prevent cancer. This is preventing primary cancer. What about biomarkers? We talked about alpha-fetoprotein very briefly earlier in this presentation. AFP, believe it or not, is not FDA cleared for liver cancer, diagnosis, risk, or otherwise. As I mentioned, diagnosis is made by imaging and occasionally by biopsy. But there are 2 FDA-approved biomarkers. One's called AFP-L3, the other is DCP. These are cleared for liver cancer risk. So elevated biomarkers indicate near-term increased risk of cancer. As you can see from this bar graph that there is a subset of patients who are negative for all biomarkers. This is data from 2006 with first-generation AFP-L3. But look at the number of patients that were positive for DCP but negative for AFP and negative for AFP-L3. 110 patients. This is why we have a subset of patients who are AFP negative but other biomarker positive. In my practice today, and dating back to 2006, I've been ordering this panel of biomarkers in all of my patients every 6 months alongside an ultrasound. These biomarkers, specifically AFP, are in 3 out of 5 of the international guidelines. Other guidelines have dropped AFP or biomarkers because people were using them to diagnose cancer. These are not meant to diagnose cancer. They're meant to indicate risk for having cancer. That's risk at a given time or risk in the near or intermediate term. Risk markers, a partnership to ultrasound monitoring, FDA cleared, and the price for these 3 biomarkers together is half the price of an ultrasound at $185, 1/6 the price of a CT scan, and 1/12 the price of an MR. It helps guide therapy. Another graph, bar graph, and discussing the number of patients who have cancer and have false positive tests. Fortunately, these numbers are quite low. So by using 1, 2, or 3 of these biomarkers, you are going to have a low chance of telling a patient they're at risk. And then true negatives are very, very high. So these are used to reassure patients that their risk for cancer in the near term is low. Biomarkers, a key part of managing patients who are at risk for cancer, determining future risk. It's a surveillance tool only as a risk marker, but not a diagnostic marker for HCC. Here's an example of AFP-L3 rising long before AFP and very long before a patient developed liver cancer. So again, this would indicate risk, help guide behavior, adjust your imaging. And here's an algorithm that I would propose. You do dedicated ultrasound surveillance and biomarkers every 6 months. If you have a poor or fair quality ultrasound or abnormal biomarkers, you're going to move to an MR scan. If you have an excellent quality ultrasound and negative liver cancer biomarkers, continue with ultrasound surveillance every 6 months. If that MR is negative, you go back into that ultrasound surveillance. You continue with your biomarker assessment, and if the biomarkers are increasing incrementally, you would go back to doing an MR scan. This is the exact algorithm that I use in my practice today. Oh, so this is very important. Patients with liver cancer have additional points with UNOS, increasing their chances of getting a transplant for their liver cancer. This table I'm not going to go into in great detail, but it talks about how we classify nodules and who gets automatic priorities. Liver transplant is curative for liver cancer. There are 6,200 liver transplants performed in the U.S. each year. And of course, if we had more organs, we'd be doing more transplants for hepatocellular carcinoma. LIRADS is highlighted on this slide. I'm not going to go into all the details, but it is a system of standardized terminology and criteria for imaging liver scans in patients who are at risk for hepatocellular carcinoma, specifically underlying liver disease. This is supported by radiologists, the American College of Radiology. It's dynamic and being refined over time. And again, this is applied to high-risk patients. A new version is currently online called version 2014. And community and academic radiologists, in my opinion, should be using this as their standard nomenclature today. LIRADS and possible premalignant lesions. This is basically a graph taking a look at dysplastic nodules that would come up as a LIRADS 4. Biomarkers may be useful to overlay on indeterminate lesions or unknown probability of HCC or moderate risk for HCC. So again, using imaging, using clinical scenarios, using biomarkers will help you determine what your next step is, whether it's intensivized surveillance or an intervention such as ablation. LIRADS categories are highlighted on this slide, going from 1 to 5. I'll leave this for you to review at a future time and review this and take this to your radiologists. A LIRADS algorithm has been developed. Again, I'll leave this for future review, but you're basically going to be talking about definitely benign, probably benign, indeterminates, possible HCC, and then you're going to go into how is that imaged by arterial and venous phase enhancement. Is there capsule? Is there growth? These are all important determinations as part of your dialogue with your radiologist. LIRADS and OPTN are coming up with a parallel system, so terminology is similar between what the radiology terminology is and what OPTN and UNOS needs for tumor points, HCC points. A little bit more on LIRADS 5 and OPTN, just contrasting these two systems. This is something for you to review as you dig a little bit deeper into our robust slide deck on HCC. A final slide on LIRADS 5 and the UNOS system, contrasting and comparison. Post-assessment question 1. Which of the following regarding LIRADS is true? System of standardized terminology and criteria to interpret and report imaging. 2, applies to patients with cirrhosis or those at risk for HCC. Categorizes observations from 1 to 5, reflecting probability of cancer or not cancer. 4 is 1 and 2. 5 is 2 and 3. 6 is all of the above. And 7 is none of the above. Question? Let's talk about management of HCC. We talked a lot about these individually and in groups, but we're going to go into a little bit more detail now. But let's go back to questions. This pre-assessment question 2. Which of the following phase 3 trials did not reach its primary endpoint? Brivinib, everolimus, ramucirumab, regorafenib, 1 and 2 only, 3 and 4 only. So really this question is what studies have come out, been published, and did not reach a survival primary endpoint? That's in phase 3 studies today. overall survival is the primary endpoint required by the FDA. Well, let's talk about liver cancer. This is a very complicated waterfall type graph. I'm going to just highlight the key points here. Liver cancer, once you've diagnosed that by imaging or biopsy or both, you're going to look at performance scores, you're going to look at their child's Kirchhoff-Pugh score, you're going to see if there's portal vein invasion, you're going to see if there's metastatic disease. We're again going to categorize those patients and discuss resection, transplant, ablative therapies, transarterial therapies, sorafenib, or supportive care. This is a very important slide. Printing this out, using this in your clinical practice is critical. This is how we dialogue as liver cancer practitioners today. AASLD and JNCI as a proposed modification of BCLC is just a slight shift in terms of how patients are categorized. They do move ablation to a lot of these early lesions as well as mid-level lesions. Sorafenib still has a prominent position in these as well. They're highlighting curative options. Again, mentioning that ablation and a subset, as well as resection and transplant, can cure. Remember, liver cancer is not one disease. It's not one disease. There's a background disease: cirrhosis, viral hepatitis, NASH, hepatitis B. It's clinically diverse. You need physiologic staging of the patient, of the liver status, anatomical staging, and then eventually molecular staging will be critical. A multidisciplinary team of hepatobiliary surgery and transplant surgery, oncology, hepatology, pathology, radiology, including interventional radiology, and radiation oncology are all critical. What do we know about treating liver cancer today? We keep pointing back to early curative approaches. We know that TACE, PAVE, which is bead embolization, and RFA can improve survival, cure a subset of patients. But eventually, most patients will be candidates for or require systemic treatment. And sorafenib today is the only therapy that's FDA approved in the US and globally. Cytotoxic therapy, currently such as doxorubicin, do not appear to have a role or impact on this disease, although there was one, I'd say, provocative phase 2 study combining adriamycin, doxorubicin with sorafenib. Sorafenib improved survival. And remember, the sorafenib trial was halted because survival differences were so statistically significant, it could not ethically continue that placebo-controlled trial. Hallmarks of cancer: we discuss signaling, evading growth suppressors, invasion, metastasis, replicative immortality, angiogenesis, and resisting cell death pathways. Geographic variations occur in the receipt of potentially curative therapy. So depending on where you live, we showed a map much earlier, the chance of having therapy could range from, say, San Jose, which was an anchor of 1, to other areas with much higher chances of having curative therapy applied. Now, this is from the SEER database published in 2006. Things may have changed since that time, but a number of these differences were statistically significant. Survival after surgical resection is dependent on size, less than 5 centimeters, absence of portal hypertension and normal bilirubin. Those patients had a 74% 5 to 6 year survival. Again, best resection candidates. How many people are resectable? 30% or less. And typically in my practice, it's been around 15%. Again, it may have to do with later referrals and more advanced liver disease at baseline. RFA, the heating of that tumor, protein denaturation, thermal coagulation, tissue desiccation. And this can cure primary tumors, but does not remove the background disease. This is interesting. 2005 study of 206 patients, unresectable HCC, treated with RFA, very favorable 5-year survival, single lesion at 61%. So RFA is a co-primary first-line therapy for patients with HCC. RFA better than surgical resection? Well, I'm basically going to summarize that has to do with patient selection, but RFA is considered a parallel first-line option for patients with HCC. Curative and local disease control rates are very similar. So be selective about who you decide for surgical therapy. Of course, this is changing as we're able to treat underlying disease very effectively today with our new hepatitis C drugs. Cure rates 80 or 90%, and I'm sure that's going to have an impact on disease recurrence in hepatitis C patients, just like we proved with hepatitis B with suppression with drugs like entecavir or tenofovir. Decreased virus, decreased recurrence. This is a cartoon about how we do chemoembolization through the artery and get chemotherapy out into the tumor. Chemoembolization, TACE versus supportive care, clearly showing superiority at year 1 and year 2 in the lower study, and year 1, 2, and 3 in the upper study. TACE, bead embolization, is part of our standard cancer management. This is a prospective study of TACE for unresectable HCC with 8,000 patients published in Japan in 2006. Excellent overall survival, but once you get out beyond year 3, survival rates start falling off because of recurrent disease in the tumor or progression of the underlying liver disease. So we think of this as a short-term survival advantage or bridge to transplant. TACE versus surgery, case-controlled study, looking at year 5, surgical resection is superior to TACE. Again, because TACE probably does not get complete tumor ablation. Resection is complete tumor ablation, of course. Radiofrequency ablation under 3 centimeters, complete tumor ablation as well. This is just looking at response to TACE as a biologic selection criteria. So people who respond to TACE do much better with transplant than if you're a TACE non-responder. So if you get TACE, there's still lots of cancer at 1 month and 3 months. Those patients do very poorly long-term and short-term. Short-term meaning high death rate. If they're non-responders and they go to transplant, they have a much higher recurrence rate after transplantation. Again, another graph about TACE as a biologic selection, TACE responders versus non-responders from auto. Response to therapy, better biologic behavior, better outcome. Portal vein thrombosis has always been a problem in our patient population. Elevated bilirubin, poor tolerance to therapy and adverse events, presence of ascites and encephalopathy. So these ascites and encephalopathy need to be well controlled before you start doing aggressive arterial or percutaneous interventions. Y90, another embolic material that puts radiation therapy on beads inside the tumor. Most data here is with case theories, but improved control of disease, regression of disease, partial response. Look at this one study from Kulik, 70% partial response by EASL criteria. Y90 is considered another co-first-line therapy for advanced disease, especially patients with main portal vein thrombosis. Even in those patients, typically dead within 30 to 60 days. Here they had a median survival of 133 days. Precision TACE, we'll talk about just briefly. This is using beads that are loaded with doxorubicin instead of oily embolization under TACE. So we call it TABE, T-A-B-E. Definitely equal response rates and less adverse events. That's really the match with precision TACE and DCBs. Response. This is WHO resist, and my favorite, which is on the right side, which is EASL criteria. Basically, decrease in arterial enhancement is the best way to describe whether someone's responding to thermal ablation, transarterial ablation, oral therapies, or other interventions such as radiation therapy. Decrease in arterial enhancement. That's the EASL criteria, when I think are the best descriptors. Patients who are candidates for transplant must fit the Milan criteria: 1 lesion less than 5 centimeters, 3 lesions maximum. None of those lesions can be greater than 3 centimeters. These patients have excellent 5-year cancer-free survival that's well over 70%. Recurrence rates, if you fit Milan, as you can see, is under 4%. If you don't fit Milan, cancer recurrence rate after transplants over 30%. Talked about MELD upgrades. We were talking about LIRADs. They get a stepwise increase in MELD score every 3 months. Try and get those patients liver allocated within 6 to 15 months by those MELD automatic upgrades. This is just looking at patients who fit Milan criteria, an excellent 5-year survival that's over 80%. This is the UCLA experience. There are patients who have more expanded criteria that have poorer survival, as you can see from this graph. So Milan is still our base, our foundation for patient selection, predicting best survival, and cancer-free survival. Molecular targets. Let's come back to this area. We talked about this early when we were setting our base therapy. Some important medications that are highlighted on here are drugs like Brivinib. That's the fibroblast growth factor receptor antagonist. And downstream, mTOR. There's sirolimus and everolimus. And back to that one question, these 2 drugs, Brivinib and everolimus, have completed phase 3 trials and did not show an improved overall survival. But again, we're going to be looking at these drugs potentially in combination with other agents. Sorafenib works at EGFR, but it also works at PDGFR and a receptor not shown here, which is a hepatocyte growth factor. Avastin, it works through this monoclonal antibody VEGF targeting system. And there's other compounds that are listed on this slide as well. SHARP trial showed this improved survival, 10.7 months versus 7.9 months. And as I said, this study was halted by the DSMB because the survival difference was so statistically significantly higher for sorafenib. But my rule of sorafenib is that 1/3 of patients have trouble tolerating the drug due to adverse events. 1/3 don't respond, and 1/3 tolerate the drug well and have an excellent response and gain not just 2.9 months, but can gain 10, 12, 15, and even up to 28 months survival after being documented to have unresectable, even with metastatic disease. Sorafenib, the first-line therapy, oral first-line therapy for unresectable HCC. This is time to tumor progression. It was much longer in the sorafenib group, markedly different than placebo. Best response by RECIST. Basically, this table states that sorafenib is a static drug, not a cidal drug. You're using the first-generation imaging. There are a number of patients, if you use EASL criteria, who will have decreased neovascularization with the application of sorafenib, probably because of its VEGF effects. There was a SPACE trial combining PACE with sorafenib. This is an interesting study, and the details are on this slide, but it was PACE with this DEB bead injection or PACE bead injection without sorafenib. Primary endpoint in this was time to progression. That did not reach statistical significance, although the hazard ratio was reduced by 20%. Overall survival was not different. Time to vascular invasion or extrahepatic disease was less, but also did not reach statistical significance. So there was a hint at benefit, but at this time we still don't know how to use sorafenib and combine that with TACE, unfortunately. So we need more first-line therapies for unresectable HCC, either to compete with or more likely to complement sorafenib. I really do see combination therapy as the most likely downstream event. We need efficacy, safety, tolerability, and good quality of life. And then, of course, we need second-line therapies for people who progress on sorafenib or cannot tolerate those. This lists a number of studies. Sorafenib and erlotinib failed, lenitinib failed, brivinib failed, sunitinib failed, and there are studies that are in progress or on hold that are highlighted on this table. There are patients who clearly benefited. This is tumor size by percentage change. You can see with lenitinib, even though the overall study didn't show a benefit, a large number of patients had substantial reduction in their tumor size. We need to figure out how to target these agents and find out who is going to benefit from these medications. We mentioned brivinib as a negative study. Everolimus, the EVOLVE study, was also negative. Ramucirumab is in development today for HCC, and regorafenib, the research study, is in development. BRISC, this is the fibroblast growth factor brivinib study, decreased time to progression, but no change in survival. We need to find out who are those patients that benefited from brivinib and inhibiting this specific pathway. Another graph showing that a substantial number of patients had decreased tumor size on brivinib. Who are these patients? Can we figure that out by biopsy and profiling? Ramucirumab inhibits VEGFR2 and its ligands, A, C, and D, mediators of angiogenesis, part of HCC carcinogenicity, pathogenicity. This is a recombinant monoclonal antibody, subclass 1, well tolerated in phase 2 trials, and is now in phase 3. Overall response rates, well, here again we're talking about stable disease, static drugs similar to sorafenib, but if we can stop disease progression, the implication is we're going to improve survival. And here again are hints about improvement in overall survival in this CP12 study. Hepatocyte growth factor, c-Met, and HCC. I just want to mention briefly that there are studies ongoing where biopsies are performed. If patients are c-Met positive, they're included in specific clinical trials. HGF levels may be associated with lower benefit from sorafenib, as highlighted in the SHARP study. More to come. This is patient survival in MET high group, and this is using a drug that's a c-Met inhibitor called tivantinib. If you're c-Met positive or c-Met high, you take tivantinib, you can double your median overall survival rate compared to placebo. So biopsies are coming. Biopsies with profiling and drug selection are around the corner. Molecular targeted therapies will play a role in the future management of HCC. Sorafenib is the benchmark medication. There's a great unmet need for patients who are ineligible or intolerant for sorafenib. We need new clinical assessment tools, specifically biopsy and tissue profiling. Randomized phase 2 trials are needed to better assess before moving patients to phase 3. Typically phase 2 or compared to historical controls or uncontrolled trials. Long way to go, but we have a multidisciplinary team and management of HCC. Let's all interact with our colleagues, move to treatment decisions, patient recruitment, treatment, and then clinical trials. Relevant specialists, treatment decision, and patient communication are critical for compliance and adherence. Post-test assessment question. Which of the following phase 3 trials did not reach the primary endpoint of overall survival? Brivinib, everolimus, ramucirumab, or regorafenib? 1 and 2 only, or 3 and 4? Please mark your answers. Practical application cases. Let's do a few cases here. We're getting down to the end of our presentation. 65-year-old Asian man, hepatitis B on first-line tenofovir therapy, no decompensation, MELD of 6, good functional status, HCC screening and surveillance showed a 2.6 centimeter enhancing mass with portal vein washout, segment 6 with an AFP borderline elevated, and was referred for evaluation. Patient had no jaundice, liver and spleen were normal, no ascites, bilirubin, a liver function test was normal, ALT, a liver enzyme, borderline elevated, good platelet count, 189, normal synthetic test through INR assessment as well. Imaging shows this peripheral lesion in the right lobe of the liver, as you can see, especially on the right scan. What are you going to do? More biomarkers, biopsy the lesion, ablate, thermal, embolic therapy. And you can see what's highlighted here is resection. This is a classic primary resection candidate. There is no current data about chemo prevention of recurrent disease. A recent study, at least a press release from this SPARE study, which is a sorafenib combined with resection, did not show a benefit of post-resection sorafenib in a broad-based study, but subset analysis is currently pending. This patient may have had cirrhosis. Would you consider a MELD exception in transplant? That should be a full discussion. Let's see, we have a man here, 6-year-old Asian man with a little bit more detail. No varices, bilirubin normal, coronary artery disease, stenting. Now we've got a 2.8 centimeter mass in segment 2, classic behavior, but in this case, an alpha-fetoprotein at sky high at 1600. Here's what the tumor looks like. Again, a peripheral lesion. Options, resection. Primary, still a strong consideration. Liver replacement with transplant, major discussion. RFA, possibly. It's under 3 centimeters. Thermal ablation is possible. PACE or bead embolization or combined therapy would all be discussed. Chemo prevention after treatment, if not transplanted. I think that would depend on the pathology of the tumor. Poorly differentiated vascular invasion, I may consider such an intervention. All right, patient follow-up 5 years later. Got a patient who had an evaluation for hepatitis C, genotype 1. Again, this is a new case. There's decline for interferon. Age 40, presents with abdominal fullness, 5-pound weight loss, fatigue, liver function is off with an albumin that's low, bilirubin high, INR prolonged, slight decrease in the patient's performance status. CT is performed, showing a 7-centimeter lesion between segments 1 and 4 near the portal vein. Classic arterial uptake and rapid washout. Ascites is seen. What's the best for this patient? This is just a graph for your future review of what the different segments are, where the tumor is located. What's next for this patient? Chemoembolization, RFA, transplant, probably not because the size is too big. Intravenous doxo, no, we mentioned that's not part of what we're doing. Yttrium 90, consideration, oral targeted therapy, TKI, sorafenib, strong consideration, and other. Please mark your best answer. This patient, we decided to treat with TACE. 5 weeks later, no residual lapidol. Tumor is now 8 centimeters. No evidence of necrosis. What are we going to do next? Retreat with TACE. Thermal ablation, unlikely. It's too large. Transplant, too large. Why 90? Strong consideration for multi-targeted sorafenib therapy. Strong consideration. We decide to place this patient on sorafenib. Optimal dose, starting dose, is it 100 twice daily, 200 twice daily, or 400 twice daily? Patient was started on standard dosing at 400 twice daily, taken without food. Patient developed a rash, grade 2 reaction, highlighted on this picture. Stepwise dose reduction took place of that therapy. And are you going to stop it? Are you going to interrupt for a week? Reduce only? Reduce by 75%? Or just treat the skin? What would be your best choice? What therapies do you initiate before starting sorafenib? Antidiarrheal, B6, pain med, something for nausea or diarrhea, other, or none? What's your first steps before sorafenib? Hepatitis C, are we going to treat this patient? The answer is yes. Most likely we're going to treat with interferon-free therapy such as D or E. I'll move quickly through these because we're near the end of our time. The patient progresses after sorafenib. Would you then consider that patient for a ramucirumab clinical trial that's available? Brivinib trials have halted. Regorafenib is in clinical trial and may consider all the above, although Brivinib is now no longer being developed. Now have 5 minutes for Q&A. I'll turn this back over to Sean and see if anybody from our conference room has some pending questions. Thank you very much.
Thank you, Dr. Gish. Does anyone have any questions? All right, I guess not today.
We covered a lot of ground. I want to thank everybody for joining us and the Access team for setting this up. And I look forward to being available in the future for other conferences.
Thank you.
Thanks, Dr. Gish. Thank you, Sparrow.
Sean.
Have a good day.